messages about sleep. First of all, we can't train, despite the culture in medicine, we can't train to get better at coping with fatigue. We may be able to emotionally manage periods of fatigue a little bit better, but your performance doesn't get, your ability to perform, your cognitive ability doesn't improve through training. Through training. So being on call as a resident for crazy amounts of time doesn't make your cognitive functioning better over time. The second message is when your impairment is affected by fatigue, you as a person can't accurately assess your degree of impairment. You know you're tired, but you're going to underestimate the level of impairment that fatigue causes. So you need to be able to anticipate when you're tired, expect to be impaired, and maybe think about engaging colleagues to assist you when you do have to work in a fatigue state, because it's a reality of medicine that we have to work at times in fatigue states. After 16 hours of sustained wakefulness, the level of performance deterioration is comparable to that if you had a 0.05% blood alcohol level, which in some jurisdictions is the point at which you can be considered impaired if you're driving with that blood level. After 24 hours of sustained wakefulness, the level of performance deterioration is equivalent to a 0.10% blood alcohol level. So simply stated, if you have if you've been awake for 24 hours, you shouldn't be driving. If you've been awake for 16 hours, you probably shouldn't be driving home at that point in time. And that's something systemically we need to think about. Even after 8 hours of duty, there is an increased risk and safety incidents in the health workforce, and that risk doubles after 12 hours. So those are a couple things I wanted to get out there about what the impact of fatigue is so that we can be thoughtful about it. We know what it is to be fatigued, but a couple key messages about impairment in fatigue, and I want you to think about ways that fatigue affects you beyond the physical. When we talk about managing fatigue, there are really two levels of intervention. I've listed systemic solutions first because that's ultimately where the main gains are. But today we're going to talk more about personal interventions because this is about personal wellness. So what can you do in managing your fatigue better? But we will talk a bit about systemic solutions. So caffeine, one of the very favorite tools that physicians use to manage fatigue. I joke when the nurses come in with their 16-ounce cups of coffee that those are called nursing cups because of the volume. Caffeine is an interesting substance. Some people have argued, and if you Google this question, you'll get some interesting articles about it. Some people have argued that the Enlightenment that occurred in 17th century Europe when ideas flourished and science took off was a result of people switching from drinking beer in large amounts to coffee. So in Denmark, as an example, in the 16th century, the average soldier or laborer drank a gallon of beer a day. With the opening of the trade and bringing coffee in, it started to create, instead of the bars that you see in this picture, coffee houses where people drank coffee, shared ideas instead of getting in drunken fights. So interesting article. If you are short of things to read, just Google that topic. We're going to go from here, though, to the first case. Dr. Ward is going to read the first case, and we're going to have some discussion around that, and then I'll talk a bit more about caffeine.
Okay, so Zainab is a general internist who has recently completed her residency and is finding the transition from residency to independent practice challenging. Her demanding schedule and on-call hours often leave her feeling drowsy and with low energy, and she has difficulty concentrating at times during her day. To cope, Zainab has started to drink a large coffee before her day and will often consume a caffeinated energy drink and a muffin from the cafe mid-morning while she's looking at her emails. Although she's getting a short-lived energy boost she needs to get through her day, she's finding that she feels increasingly irritated and anxious and has difficulty falling asleep. Further, she's finding it increasingly difficult to recall details from patient charts and during patient handovers. So Dr. Degg, what do you think about the way she's using caffeine?
So let's put that out to the audience. So any comments about how this person's using caffeine and the way it may be less than helpful? Anybody, feel free to jump in there, or you can type in something in the comments. Anyone? Not enough?
That jump, she's getting that jump on the day.
Yeah.
Seems like it's gonna work for her.
What do you think about the timing of her coffee? Sounds like a normal physician, doesn't she?
What time did she drink it?
So she's drinking a large coffee before her day, and then she'll often get a caffeinated energy drink and a muffin mid-morning.
Sounds like a typical time.
Typical physician. What do you think that large coffee is now, too? Does anybody know how big those really big Timmy's cups that people get, the ones that look like a thermos? They must be at least 12 ounces.
I think they're 16.
16 ounces, yeah. So you know how much caffeine that is? That's about 300 milligrams of caffeine in one coffee.
And then you have a muffin and you crash.
Yeah.
So then you have coffee because you crashed.
Yep. Yeah, so I'm going to go back to the slides. So first of all, caffeine withdrawal. So we're going to do a quick poll here, a quick quiz to see what people think. Petra, can you run the quiz now? So how many 8-ounce coffees do you think you have to drink each day in order to develop withdrawal symptoms?
Sorry, is 8 ounce the normal size?
Yeah, well, if assuming 8 ounce, which is probably smaller, what do people think? Is it so everybody pick a number and then we'll get Petra to show the results. Do we have the table of results up, Petra? There it is. Okay, we've got a smart group of physicians here. 94% says 3 cups of coffee. So yeah, caffeine withdrawal can occur with 400 milligrams of caffeine a day. So 3 cups of coffee. That 160 gram, and depending on how that coffee is brewed, that ultra large cup could be enough to trigger withdrawal in itself. Typically, withdrawal occurs within 12 to 24 hours, but it can be in as little as 3 to 6 hours. And the symptoms, as you see, include fatigue, headache, impaired performance. So it looks like fatigue. So you can get people to actually chase the caffeine. So she's having a large coffee in the morning, another or at the beginning of the day, another mid-morning. So she could be withdrawing even by the end of the day, and probably is withdrawing by the beginning of the next day. So one of the issues with caffeine is withdrawal and the timing of caffeine. So remember, first of all, that using caffeine, the average duration of action is 4 to 6 hours. So think about that at the end of your day as well. So if you're working a 12-hour shift, you have to think about when you use the caffeine, because if you use it too close to bedtime, then it's hard to get to sleep. The onset of action is 25 to 30 minutes, so it doesn't work right away, although we often have a psychological boost that I think has to do with the flavor of caffeine. Some people would suggest that actually in the morning you start with a decaf coffee, because you may arouse normally without caffeine, and if you load up caffeine earlier in the day, you could be at the dose where you're starting to get significant withdrawal symptoms. So think about timing and the dose when you're using your caffeine, because it can disrupt sleep that can feed into fatigue. So the next case, yeah, so let's go over the next question now, the next case.
So what strategies might Zainab use beyond caffeine to manage her fatigue? Want to throw that out to others?
Yeah, any thoughts for other people, for the members of the audience? What else could she do besides her current approach to caffeine?
In the chat, Carol, which I know you're struggling to see because of the presentation, Tammy is suggesting she moves, others are suggesting exercise, Jennifer is suggesting deep breathing, meditating. Liz Parfit, how are you supposed to get out of bed without having a coffee? Jokes. Eyes closed yoga, getting out for some fresh air, ice cold water. So some of the suggestions, Paul, that are coming from the group.
Yeah, so lots of good ideas about other ways to manage that fatigue and tiredness. So it's about timing of caffeine, but it's also looking at other things you can do. So how do you get a break during the day? And we'll talk a little bit about that. And also looking at what are things that might be adding to fatigue outside of work. So work is stressful and fatiguing. Are there other factors that she needs to pay attention to? So getting sufficient exercise is a critical piece of that. So let's go on to the next case. I'll pass it to Carol to read it.
Okay, so Phil is 31, married, and recently became a father and works as an emergency physician. He drives 45 minutes each way to the hospital and typically completes several 12-hour shifts in a 30-day period. Recently, Phil drove off the road on his way home from work at 6 a.m. This was not the first time he felt tired. It was the fourth time in the past 6 months that he'd had a close call while driving home after an evening or night shift. But this time, it frightened him. So he stopped his car, he walked around outside in the cold air before he continued home. Although he's been avoiding talking to his department head or colleagues about driving home tired, this latest incident was the trigger for Phil to tell his wife. Now that he has a child, he feels more strongly that he has to make some sort of change, because his stories about nearly falling asleep on duty or on the way home from work have scared his wife. Phil thought he could avoid an accident, but now realizes that he could hurt himself or others if he doesn't make a change. So Dr. Dagg, how could Phil improve his sleep?
And this is something, again, we'll turn it out to people. So what do you think about this scenario in terms of how you can manage it? I'm sure some of you live this on a regular basis. What are some of your thoughts about this situation? Uber, yeah, one of the things is what is your capacity to get an alternative drive home when you're tired? That's a challenge, I understand, but it is something to think about because there is an increased risk of motor vehicle accidents, even after what we consider a normal shift, especially if it's occurring outside of circadian rhythm. So that 12-hour night shift. Yeah, get a ride, walk if possible. I can see this, I've got finally, after years, I've got the comments up. So one of the issues is taking the role of napping. And I'm going to talk about that very specifically with my next slide, because it is something that can be helpful in this circumstance. And if you think of caffeine and napping, how you do things strategically, this is the issue of using there are countermeasures that you can use, but you have to use them in a way that they're helpful. So what the caffeine story illustrates for us is caffeine is in fact a useful tool when you're fatigued, but you have to use it carefully and use it in a way that it doesn't cause difficulty. And we'll talk about breaks and napping as well. So thinking about how he manages that 12-hour shift, when he uses that coffee, if you use that method, when you take a break, those sorts of things. And the other thing to think about is what's the shift rotation look like and how quickly are you switching circadian rhythm? What is his life cycle like? So are you working 12-hour night shifts and then working during the day as well, or is your family life busy during their day? comment by Joanne, an excellent comment about making sure your sleep environment. So the shift work is challenging, but it's making sure you're getting good sleep when you're able to sleep. So what's your sleep environment? What's your sleep hygiene look like? So making sure if you're sleeping at odd hours, yeah, maybe you've learned to sleep with lots of light, but maybe you'd sleep better with blackout curtains and less noise. So looking at these things to make sure that when you're off duty, you're sleeping as effectively as possible. So I'm going to flip back to sharing the screen. So napping. So napping is certainly useful. The ideal length of a nap is between 20 and 30 minutes. If you sleep longer, if you sleep over an hour, you get into sleeping potentially a full sleep cycle, which may feel good. The challenge is at that point, you start to repay some of that sleep debt that we talked about earlier, and it may impair your ability to get a good sleep the next night because you kind of start into that and then you wake up and go. So a period of sleep that's too long can actually cause difficulty with initiation of sleep.
Not sharing your screen.
Oops, sorry, thank you.
Before we get too far, thanks.
Okay, thank you. Yeah, so sorry about that. Yeah, so napping, the ideal length of napping is 20 to 30 minutes. The timing is critical as well because too late in your day can impair sleep later. So if you fall asleep after supper for 20 minutes and then try to go to bed 2 hours later, that can again impair quality of sleep. So if you think of Phil's situation, so you think of the ideal time in a regular day to nap would be between 2 and 3 p.m. in the afternoon. So in that 12-hour shift, it's not waiting towards the end. It may be strategically resting or napping earlier in the shift. And some people have talked about the caffeine nap because when you awaken from a nap, you get this period of sleep inertia where you can feel tired and it takes a while for your brain to get going. And so caffeine followed by a nap means that by the time the caffeine onsets, the sleep, by the time the caffeine onsets, you're waking up. So planning and timing of sleep and sleep and napping is important, but also planning and timing of your day. So the most problematic activities when you're fatigued, it's kind of a dual-edged sword. It's those activities that require high levels of sustained concentration and attention, or conversely, routine tasks requiring low effort. So if you have control over your workflow at all, and often I know we don't, especially in clinical medicine, being thoughtful about what you do when. You can manage the high stress, high acuity, brief events, even when fatigued, quite effectively. But it's those things where you need that higher level of concentration sustained over time, or things that are relatively routine. Routine, low-risk things would not be a concern if you're fatigued, but routine tasks, routine in the sense that they're repetitive, but with higher risk, you need to be careful. So if you're thinking about your day, if you have control over what you do when, keep that in mind. Consider where possible safety critical work accordingly. And then the other issue is be aware when you are fatigued or when you're likely to be fatigued, and be aware when your colleagues are fatigued or likely to be fatigued, and ask for help or offer help. So it may mean that you are still doing your job, but you might want to let somebody know that you're feeling tired. So if they could just keep an eye on things. And, as teams, we should be keeping an eye on each other's performance at all times, but it is something to pay attention to. If you're working with a colleague, unfortunately, we do have our nursing colleagues certainly working extended hours. 16-hour shifts are not unusual. And I know some have been working 24-hour shifts. I think that's a time we need to be attentive to what that person is doing. So think about asking for help when you're doing things at high-risk times. Maybe get somebody to check over your orders if it's something where there's potential risk and challenge. What we will do is, maybe Carol, you can ask the second question. I'll stop the share so that I can see comments, and you can add the second part of that case.
So Paul, are there potential system interventions that could help?
So what do people think about that? What are some of the potential options systematically that could be considered if you were Phil, or if your department had working with people like Phil? What are some of the things that you could do to help manage fatigue? Yeah, so one of the things, I mean, in healthcare, we love 12-hour shifts, and there's lots of reasons we love them, but it is something to think about, is what is the efficacy of 12-hour shifts? Or particularly if we're relying too much on 16 and 24-hour shifts, that's something definitely to think of. The challenge, of course, is 12-hour shifts are popular because it means you have some time to do all those other jobs of life when you've got your days off. But it is a time to think about, and maybe it's just a time to be aware that we need to be attentive to each other when we're coming off 12-hour shifts. Randy Grahn brings up the issue of the mandatory siesta. I mean, there are some cultures where that is a part of life, but it does mean if you're in a situation where you can take a break, you know, this is an area where our nursing colleagues do a better job than we do. You know, certainly it's part of their union culture, but it's also part of their culture that, you know, they talk to each other at the start of their shift and they say, we're busy, but when are you taking your break? I'll take my break then, you know, this kind of thing. So in medicine, we don't tend to talk about breaks. We don't tend to take breaks. But it is something to think about. Certainly for pilots and people in safety critical jobs of that nature, they have mandatory rest times. They have no choice. They have to rest. And if somebody hasn't had their mandatory downtime, they can't, you know, that plane, the next flight is delayed until the pilots and crew have their mandatory time. Jill brings up job share around shift allocations. Live closer to our workplace. You know, that's a way of managing things. The ability to walk to work is certainly a way to manage fatigue. Office yoga mat. You know, finding ways to take a break during the day. Napping is one thing, but just have a brain break during the day, at least is partially restorative. I think of in Seinfeld, George had the nap desk, where he had a desk with a built-in nap shelf that he could nap, and then you have a picture of yourself so it looks like you're busy if somebody peeks in the door. So maybe this is something to think about. But that issue of taking a break, yeah, I mean, this is an interesting issue that Jill brings up, because this attention to physician fatigue is a big issue from a litigation standpoint. It's certainly an area where healthcare is paying more attention. This is going to, at some point, if it's not already, be an accreditation standard for Accreditation Canada. And this issue of, should your patient know if you've been up, if you're finishing a 16-hour shift, or where you are in your shift? You know, if you look at the performance data, they probably, you know, it gets into consent issues. You know, the reality is we often, as I said, depend on people working fatigued. But, you know, I think there's opportunities for changing culture in terms of how we think about healthcare shifts. I think one of the difficulties in North America is a lot of the focus for physicians has been on resident workload and resident duty hours. And part of my participation in this task force was to remind people that we have to think about physician workload, but also be aware of physicians working in smaller communities where they're, you know, you don't have enough people to do a night float kind of system the way they do in residency, perhaps. But this is one thing for you, for those of you who haven't been in residency for a while, there are programs now that are doing night floats. You have a resident who is doing straight nights for a week, 8-hour, 10-hour shifts, so that the other residents aren't doing any nights. And then you come off night float and work during days. So, you know, I think it's time to opportunity to think about you know, how we work. Really good comment from Elizabeth Parfit about what are you doing in your break. So our idea of a break is we go and look at emails. And that was that first case. Looking at emails isn't a break, or looking at your phone isn't a break. Going on social media is probably not the best thing to do because it cuts into some of those issues around how do you really shut yourself down. So thinking about how we use breaks in a healthy way is, I think, something important. I'm going to start my screen share again and see if I can get it right this time. There's the first stage. I always have to remember the second stage. There we go. So I want to spend a bit of time on culture because this is something I think we have to pay attention to, and it's the medical culture around fatigue. Number one is we have to create a culture where you ask for help and where it's okay to potentially say, I am too fatigued to be safe at this point. And I know, you know, the culture in medicine is we suck it up because everybody's fatigued. But you do have to be prepared to say in healthcare when you're too tired. In Australia, it is illegal to do a 24-hour shift in healthcare in any field. And I think, you know, when we think of, that's why I think this is a healthcare issue. It's not just a resident issue. It's not just a physician issue. But it's a particular challenge, I think, in physician culture, because our culture is about sucking it up, being tough. You know, when we were residents, we did et cetera, but recognizing when you are impaired and need help. And sometimes I did a presentation like this to the board or to the senior executive team, and Doug Cochran commented as, you know, his experience as a surgeon. And he said, you know, there are times that in retrospect, you know, I was impaired in the OR. I needed to do that surgery. That surgery couldn't wait. But I should have, at that point, at least said, guys, people, team, you know, I'm not at my best. So just, you know, be aware of that. Help me through this, and we'll get this procedure done. So we need a culture of asking for help. Check in with others. You know, so I've got in a habit now, if I know a nurse is coming off a 16 or 24-hour shift, I ask them how they're getting home. And, you know, often, fortunately, they have rides, but I'll use the numbers around impairment when that happens. And I think it's something with our physicians. If somebody, remember, one of my first points is when you're fatigued, you know you're tired, but you don't know how impaired you are. So if you're, you know, if you know somebody has worked an extended shift, or you know somebody's worked a regular shift, but they've got a new baby at home and they're not sleeping well, check in with that person to make sure they're doing okay, because fatigue obviously isn't just about medicine. Acknowledge your fatigue because we're role models. So I think I mentioned this in one of the earlier talks. You know, I'd had earlier on in this thing, you know, you walk by one of our team and they say, hi, how you doing? And you say, fine. And I said, fine. And then I said, hang on, no, actually, I'm tired. And, you know, and she said, yeah, me too. And like we go on with the day, but you at least acknowledge to each other that you're tired and don't pretend you're not. Acknowledge potential impairment. So if you're doing something that's particularly critical, acknowledge it and get some assistance on it. Think about, you know, I think about just seeing Jill Calder's name. I mean, I think about people in radiology like her husband, Bob. I mean, that must be a challenging job when you're fatigued because your level of attention has to be right on. And yet you're in a dark, quiet room and trying to maintain the same level of attention that you do when you're not fatigued. Challenge the way things are done. So think about how we use circadian rhythm. And I've talked about this perhaps in other examples, but I'll give the example again, and it comes around culture and fatigue and how things are done. I've got a teleconference coming up in a couple weeks. It's with the Royal College. It's about academic certification. So it's not anything emergency. It's a teleconference. It's from Ottawa. They've got it scheduled for 8:30 Ottawa time, so it's 5:30 BC time. And you know, that's just ridiculous for a routine teleconference because, of course, it means you're waking up at 5 a.m. to attend to this teleconference. Circadian rhythm, the time to really protect if we can, is that time between midnight and 6 a.m. Sleep disturbance within that time is going to have more profound impact at other times. But you know, the culture is you don't say anything. You just show up and somebody says, boy, you're up early, and you say, yeah, and you laugh and you have another big gulp of coffee. Whereas, you know, we need to just say that now that we're doing video or teleconferences, you know, we shouldn't be scheduling them in Ottawa unless it's something critical before at least 10 o'clock in the morning. And it's okay to say that, because part of the culture is you're not supposed to complain about having to get up at 5:30 in the morning for a teleconference that's really not that earth-shattering in its complexity. So challenge the way things are done. Look at the way things are scheduled. And think about protecting that vital time, particularly that circadian time, as much as we can, recognizing we're a 24/7 business. And then we need to advocate for systemic change. We need to look at how healthcare services are delivered, and that's where Accreditation Canada's, you know, for example, looking at requiring healthcare organizations to have fatigue risk management policies and programs. Because if we don't do it, you risk legislation that could make our jobs much more difficult than they are, and not get at the basic issue. Because even with duty hour restrictions, fatigue management is still an issue, because you've got, at the very least, shift change and people being fatigued for other reasons. So this is a reminder of one of my first slides. So again, think about times to tap out. It's a hard thing to do, because when we tap out, it means other people are doing our job for us, and they may not do it the way we're doing. So part of tapping out means allowing yourself to hand off to somebody else. It means letting somebody else carry the baton. And if they're not able to, then we need to assist them to get to the point where they can do it. So we need our teams to be able to tap out. We need people to be interchangeable. Here's a trivia question for people online. The bottom picture, why do you think I've got that bottom picture there when we're talking about passing off things to other people? We'll see who recognizes that. Anybody? Paul, I'm not looking at comments. Is anybody coming up with what that game is and why it's critical in this?
Not seeing any, and I'm going to claim cultural ignorance.
I know.
So Carol knows. Carol's going to say why.
It's ringette, right? And
Yeah.
Yes, and they have to pass the puck or the ring.
Ringette in contrast to hockey, and if there's anybody, there's a big ringette team up in Salmon Arm. They've got a lot of ringette. So the rule in ringette is you've got to pass it across the line. Any line, you've got to pass it. You can't carry it with you. So that's why the ringette analogy. I was looking at getting a good picture of women's hockey, because women pass more than men do anyway in hockey, but ringette is about a game where the rules are around tapping out. So we need to make medicine like ringette. And we need to think out of the box. So just the last couple slides, and then we'll open it up for broader discussion. This is just a tool for you to use. So if you're looking at your own particular situation or your team situation, this is from the Fatigue Management Task Force. The link is on the resource slide. And this is just a model where you can look at how you address fatigue issues. So it's a breakdown that just shows, first of all, how you acknowledge identifying the issues, and it helps you look at things like circadian principles, work hours and scheduling, breaks from working, work demands, task demand, which is the level of task demand, assess what's going on, and then look at ways to act on those things. So if you're looking at a quality project around fatigue risk management, this is a really useful tool to use as a base to think about your workplace. And these are the resources. So the first is the link to the Fatigue Risk Management Toolkit. It's on the Resident Doctors of Canada website, but if you just Google fatigue risk management, it comes up. You may have to put in physician. The 15-minute consultation, so I didn't include the author's name on this, but this is a really useful, very short article about managing the effects of shift work on your health as a physician. So it's an excellent article. Transport Canada has their This is a publication that's their fatigue audit system. So it's a system of how to audit fatigue risk in a situation. Really useful tool. The fatigue severity scale is a self-assessment tool that you can look at as a tool to use within a workplace. And then the final one is a video interview. Professor Drew Dawson is one of the world experts on fatigue in healthcare. And this is a video panel with himself and Dr. Carmel Harrington, both from Australia. And Australia's done some amazing work in this area. It's about a 40-minute interview, but it's a really interesting discussion by some of the world experts on fatigue. So if what I've talked about today is just whet your appetite for more, that'd be a place I would start.
Paul, thank you. I wonder if I could just summarize as I've read some of the chat. So there's been a conversation going on with a couple of folks around feeling that the culture we work in doesn't necessarily always empower us to feel, one, ready to ask for help, and secondly, is not built to help protect us in those difficult situations. So often we work alone, we work in very short-staffed groups. We're very concerned about putting extra workload on others. What could you say around, the scheduling piece or the culture in which we work that might help support docs leaders who are struggling with that kind of thing in their departments?
Yeah, I mean, this is a challenge of healthcare because this is how healthcare is constructed, especially outside of large urban centers. It's constructed on the bare minimum of staffing. It's fun. We're paid so that our incomes require us to work in situations with the bare minimum of staffing. The whole system is built on this. And I think so, first of all, we need to start to advocate at some point to move to a healthier system that's less volume dependent and more and healthier. Having said that, I think it's about where can we make some small changes? So how can we look at scheduling so that as much as possible we're protecting people's sleep cycles? And I think as leaders, it's critically important that this is an area we role model. Our leadership in general, what we role model, and I use, although I'm not in a formal leadership position any longer, I've been in it a long time, and my approach always was, well, I'm going to show that I can just pick up the burden. I can take more on, and I'll take more on so that other people will have less to do. And that's the medical culture, but that's where I think as leaders, we have to role model something different, because our new colleagues coming in are going to, they get acculturated very quickly to the same kind of model. So it's recognizing that we do work in these conditions of probably chronic fatigue production, but maybe recognize those points at which you are more tired than usual and look for an opportunity wherever it exists to either look at how your day is planned or look at how, see if you can share that load with somebody else. And I'm just going to turn my screen share on, because if you look at this slide, it is recognizing that fatigue is multidimensional.
Not seeing it yet, Paul.
Yeah, I always miss the second click. So there's always the second click. So anyway, with this slide, again, you can look at, it forces you to step back and look at what are other things contributing to fatigue beyond simple workload, and think about that. And think about as a group how you work together. I think it's about looking at our physician human resource plans. We're generally built on, as I say, just enough physicians. And often we've got situations, I know from my experience in psychiatry, we've got situations where we're well below the just enough level. Or our model of just enough is just enough to cover the call schedule. Well, we probably need to start to move to a situation where rather than just enough, we're at just enough +1 or just enough +2, so that we have ways of covering a call schedule. That has an impact, that's a challenge, because that has an impact on on other aspects. And I know, I can speak from psychiatry. It's probably easier in psychiatry than, say, procedural disciplines where there's limited access to OR space or other systems. So I think the simple thing is role modeling and addressing the culture of working through fatigue by acknowledging fatigue and acknowledging that fatigue can affect performance. But thinking about how our workload is constructed. Are there tasks we're doing that we can start to look at shifting to other people and maybe look at alternatives to physicians even and things of that sort? So it's a kind of thing that's going to require big systemic change. At the personal level, it's make sure that the countermeasures we all use are effective and aren't making the thing worse. It is about paying attention to wellness. I think as physicians, as a rule, we're probably better than average in the general population paying attention to physical fitness and physical wellness, but it is paying attention to how we attend to wellness broadly. What else is coming up? You've probably been tracking the comments better, Paul. Any other themes coming up?
So I just want to sort of comment on something you just said, that while there are bigger systemic changes needed, I think the point you made early on in that dialogue was how valuable and how powerful small and individual changes can be, and how you model that within your own group, within your own working partners, etc. Just a quick anecdote from my own COVID experience recently. I walked into hospital sometime in the middle of April, and I was acknowledging to myself that I was feeling pretty exhausted from a couple of days in the hospital, in long days. And I bumped into a 60-something-year-old family physician colleague of mine, and I said, how are you doing? Checked in with him. We're fairly friendly. And he kind of very brushed off this whole thing and saying, I'm so used to doing 100-hour shifts all my life. I don't know what people are fussing about. And I found it incredibly deflating. One, he didn't check in with me. Two, he was not acknowledging any of the signals I was giving him that I might have been tired, and simply took that position and was completely deflating. I went straight into a meeting in which I was working with some leaders in a group who took a completely different approach, and we were able to do some work, celebrate some successes, recognize some challenges, and continue to move forward. And I came out of that meeting feeling completely different. So the interesting thing for me was my baseline level of fatigue was clearly still the same. The way I experienced even those simple interactions completely transformed the way I felt. And so the point that Liz, I think you made to Lornie in the chat, was that how we acknowledge one another, the time we take to check in, is the small way in which we can dramatically influence culture that then allows, and ushers in how we make those changes at a bigger level. And certainly for the, group leaders on the table, as we think about resource planning, moving forward at a provincial level, Paul, I think, what you've argued for, and one of the colleagues said earlier, how's the college looking at this? So I don't know that the college is looking at this particularly, I'm not sure, but I certainly think it should be, and certainly should be a thought in how we think about resource planning, and onboarding young colleagues who potentially come into medicine today with a different culture, as I illustrated in my story, than those who are, getting into retirement soon.
Oh, can I just jump in 2 comments and I'll pass it back to you to wrap up, and I know we have a poll, because I just wanted to highlight 2 things that you said that I think are critically important. Remember the earlier slide on the causes of fatigue. That fatigue's caused by physical things, absolutely, and so we've talked a lot about those physical things, but it is triggered by emotional issues. So stress causes fatigue. Stress can make the experience of fatigue worse and can affect your sleep. So that makes so that emotional intervention is something we have control over and is something we can deal with. And I think the point you raise is there is the myth that because I've always worked 100-hour shifts, I can do so. Yes, you can, but the evidence is your performance isn't as good at these certain marker points, regardless of how many times you've done that. So those are my final comments.
Just in the last couple of minutes, are there any sort of final comments out of the chat? If you want to turn off your mic and raise any further questions for Paul, or let us know any of your thoughts on some of the discussion.